Thank you very much. Good afternoon, everybody. Thank you to Phil, and spare a thought because he tells me he has done back-to-back chairing from 11 o'clock till 3 o'clock this afternoon without a break. So he's still looking very good on it. Can everybody hear me all right? It is like speaking at Speaker's Corner here, isn't it? And quite tiring for you in the audience. So as Phil said, I'm from Brighton Integrated Care Service. I'm going to talk to you about a referral management gateway and how a referral management gateway can be used, how commissioners can use a gateway to support a number of commissioning functions. Those are that it helps get patients to the right place first time round. It enables you to deliver choice, to discharge your statutory obligations around delivering choice. It generates data, an enormous amount of condition-specific, presenting condition-specific data, which that data allows you to design care pathways around specific conditions. It also gives you a lot of individual clinician-specific data. And you'll see, I hope, how that data can be used to give feedback to referring clinicians. And it's that feedback which enables clinicians to identify their learning needs and address them, and also gives them the feedback enables them to embed new clinical pathways in a way which I know of no other way that's as successful at embedding clinical pathways into everyday clinical practice. That data we will show you demonstrate that there's a huge amount of variation. And I believe that addressing variation, interclinician variation, is the next big thing in terms of transformational change around, specifically around, in this case, how to manage and contain demand. Lastly, if we've got a moment, I'll just touch on, but this is not because I wasn't originally scheduled to speak about this, but how you can apply the lessons from elective care that we've got experience of the doing into unscheduled care as well. Aha. So just a little bit about context then. We're used to working in systems which are very supply-side led. They have suppliers tell us what they provide, what services and what type of services they're going to provide, and how much they're going to provide. And part of the transformation that's needed about smart commissioning is about actually moving to a demand-side model where you really understand what the demand is, what it is that generalists are asking for when they refer to specialists. And that touches on the fact that the referral decision that individuals, clinicians make is essentially a commissioning decision. And the referral that takes place is a transaction. So it's only by understanding and developing an understanding about what it is that a clinician is asking for, and understanding that in detail, that you can start to add granularity to your understanding of what services you need to commission. So, for example, you might know that in your health economy you've had X number of referrals into digestive diseases. What a gateway will be able to tell you is what proportion of those referrals into digestive diseases were for dyspepsia. and what proportion were for, say, acute inflammatory bowel disease. And that's important because the outcome, the pathways that those patients follow are very, very different and have very different cost implications. So this is just who we are. It's a picture of my office. We're a not-for-profit social enterprise owned by the GPs and practice managers and practice staff and our own staff in Brighton. And you can find a lot more information about BICS on our website. We do referral management. We provide referral management gateway in Brighton and in Croydon. And we also provide a range of clinical services. And our clinical services are all characterized by developing partnerships, by providing integrated care services that bring together different providers into partnerships. And they have a second characteristic, which is that they all seek to bring more work and investment into primary care and extend the scope and the capacity of primary care to deliver more within a community setting. The gateway part of what we do, we process about 550 referrals every day. And those referrals we harvest data from each one of those referrals and copy that onto a database. We peer review selected sieved numbers of those referrals, and that sieving process about what goes to peer review and what can go straight through can be switched on and off and is very flexible. But essentially, we target the peer review element to those conditions where we know that there are either specific alternative providers that we can stream patients to, or that GPs or referrers struggle with. We're able to stream all of the referrals that are appropriate to go into community non-consultant type delivered services can be streamed into those services. So that means you can maximize your use of all your community clinics without having to rely on GPs having to individually remember about the existence of every community service at the point of writing the referral. We also contact all patients, make contact with all patients, and have a choice discussion with them. So they have a one-to-one choice discussion about where they can go for their outpatient appointment or their specialist appointment, and what time. It's often the what time is the most important part of that choice discussion for patients. We also act as a point of contact for patients throughout that referral journey, from the point at which the referral leaves, or in fact, from the point at which the patient leaves their consultation to the point at which they have their specialist appointment. We act as a point of contact, which is something, so it's providing a kind of stewardship role, which consistently the feedback that we get from patients and from referring doctors is that that's a role that's highly valued. And in doing that, we've been able to deliver a 2% reduction in 2% total reduction in new referrals year on year within the areas that we operate, as opposed to a 6% growth nationally. And that it is a service that pays for itself. So the savings that it raises cover the cost of delivery. So I talked about variation earlier, and let me just tell you about this slide. This is demonstrating all GPs or all salaried doctors and partners in Brighton and Hove. Each one of them is represented by a vertical bar. It's about 160. We use a proxy measure, which is the number of sessions that a doctor works. So it's a proxy measure of the number of consultations they do, because it's reasonably deliverable, whereas actually asking for the number of consultations is an ask too far. We have a mean for the city, and this is referrals per 100 sessions for all specialities, not in this case mental health when this chart was produced. And what it shows you is in line with actually the international literature on this, is that you have a high degree of variation between clinicians. We're running at about 6-fold variation. Literature talks about anything between 2 and 20-fold, but commonly that 3, 4, 5-fold variation between the lowest referrers and the highest referrers. Now, in order to modify demand, it's generally agreed that reducing that variation is a good thing, and particularly reducing unexplained variation. So you need to understand a little bit then about what we already know about variation in practice. We know that there are these 4 things: patient characteristics, practice characteristics, access to specialist care, and then this last one, individual practitioner characteristics. Excuse me. The first 3, well, all 4 of these have both factors which are modifiable and some non-modifiable factors. So in patient characteristics, for example, you can't change demography, but you can change things like cultural behaviors. So we know that Eastern European migrant workers have a very different expectation of primary care to the general population in the UK. So these first 3 are things that we, commissioners, systems, have been doing a lot to change for a number of years. And it's this last one, this individual practitioner characteristics, which is the thing, as I said, that has been very difficult to talk about at all. But now, I believe, is the time that we need to start exploring more about that, and we can show that you can do things about it. You can't modify, there are things like age and gender of doctors, which you can't change, but you can change all of these things, and these are all known to affect where a doctor sits on that variation curve. So training, experience, their ability to tolerate uncertainty, their sense of autonomy, personal enthusiasms, ability to respond to patient pressure, and individual cognitive processes. And on that one, the bloke at the bottom here is Bayes, who was a 17th century mathematician and Presbyterian minister. And he was the inventor of Bayesian inference, which is basically about probabilistic reasoning. And that is your ability to work out the probability of something happening using all the evidence that's available to you. And there's all sorts of things that happen within the way doctors think that affects that. For example, this idea of the availability heuristic, which is that when something terrible has happened to me, when I've had a patient with irritable bowel, with all the hallmarks of irritable bowel syndrome, who's age 40, who turns out to have bowel cancer, I'm very, very reluctant not to refer every single patient that I see with irritable bowel syndrome thereafter. So that's a concept that many clinicians will be familiar with, but it doesn't mean it's the right thing for the next patient. A little bit more about the data. This is the data for dermatology for a single practice in Brighton, broken down by a range of presenting conditions. Now, they're all too small for you to see, but here's a magnified view of it. And what it shows is this doctor's activity, or this practice's activity, over the last 3 years against the city mean. The horizontal line is the city mean. And it shows you that this practice is very high, is well above average in acne, in BCCs, or suspected BCCs, and in benign skin lesions. And that is telling you a number of things, and then we also know a number of things as well. So we know, as it happens, that the particular practice that this involves was at the time experiencing a lot of difficulty with having to use a lot of locums because it had lost a partner. It also then allows you to provide this kind of level of macro feedback to the practice, allows the doctor to identify their own learning needs, or the practice to identify learning needs, which in this case might be around acne and managing skin lesions. And for them to start having to explore their own thinking about, well, what is the issue here? Is it one about knowledge? Is it one about confidence? Is it about my ability to live with uncertainty? Is it about managing patient expectations? And then what we can also do is use what we call, so that level of data we call macro feedback. We also use micro feedback, which is the conversations which our clinicians, our triage clinicians, can have with referring doctors as soon as we receive a referral. So if this doctor's next referral for acne may prompt a conversation where the triager is able to go to contact that doctor and say, I'd like to talk to you about your referral for John Smith with acne. Can we talk through what you've done so far, the acne pathway, and so on? And that is a very potent way of embedding pathways for that doctor. And then just very quickly, this just shows you, this is a doctor who's labeled as high referring. It just shows you actually that their high referring activity is pretty much across all specialties, whereas there are other doctors demonstrate different patterns, so which may reflect a particular area of lack of confidence or lack of knowledge. And then just this is the top, the doctors who are more than one standard deviation above the mean for referrals for dyspepsia. And you can see some people are very much above the mean. But this allows you then to be able to target specific education and development at a particular cohort of doctors. And then just on dyspepsia, this is just to demonstrate that this is what the power of this. We introduced, we did a soft introduction of a new dyspepsia guideline in early 2010. And just by actually taking nice guidance and putting it into a digestible, pardon the pun, format. What that shows is that we were able to achieve about a 50% reduction in referrals. This is referrals received for dyspepsia. So there was an initial period of having a lot of feedback conversations with doctors who then assumed the knowledge and actually stopped referring. Now, I'm going to stop there because I'm very conscious of the time and open this out to any questions. Thank you.
Good. Just briefly to introduce Dr. Jonathan Serjeant and Zoe Nicholson, who are both directors of BICS, and we can take a few questions. So if you have a question, please stick your hand up and we will get the microphone to you. There's a question down here on the middle aisle, please. And stick your hand up as soon as you've got a question, because then we can get the mic to you after that. Thank you.
Hello, thank you. I'm Javed Ahmed. I'm one of the GP registrars. My question would be that if it doesn't necessarily mean a high referral is an inappropriate referral. So my point, something that would interested me would, in that data would if you shown that the high referrals were inappropriate in proportion in referring rather than the high numbers.
Okay, so the question is about the appropriateness of referral,
Yeah.
really.
It's a very good question, and it's not just about appropriateness, but where should the mean be? And the answer is nobody knows. So we are very careful to avoid using the language of appropriateness because actually it's not appropriate to use that language. And we're very conscious also of